My name is Dr. Gojer, and I'd like to thank everybody for inviting me to this presentation on challenges with communicating, keeping the wheels of justice rolling. I'm sure that everybody in this audience will have some information and some ideas about how to communicate with the mentally ill client in the courtroom, but I hoped to put everything together in a presentation and to generate some discussion. And I hope that at the end of the talk, there will be something exciting for everyone to share. Let me start off by quoting Tony Robbins. Tony Robbins said, "To effectively communicate, we must realize that we're all different in the way we perceive the world and use this understanding as a guide to our communication with others." Before we discussion, I'd like to talk about a young client who presented to the court offices a few months ago. This is an individual who had been charged with threatening his brother and had a knife with him at the time. So the charges were related both to threats and the possession of a weapon. And he was not allowed to go back home. He moved into a downtown shelter Covenant House and then was referred to us. When he came to us, he presented with a flat affect, had minimal conversations, hardly communicated, and denied that he was depressed. We suspected that there was some paranoia towards his brother, but it was difficult to extract that information from him. He hadn't been born in Canada, was in this country as an immigrant. And a provisional diagnosis of a psychosis, possibly schizophrenia, was made. And on a trial basis, we decided to start him on an antipsychotic drug. He seemed to do well, and in the follow-ups was more settled and had talked about going back to school, but was very keen to move back home. We referred him to another hospital to follow up with a psychiatrist, and he was linked with a psychiatric team that included a psychiatrist, social worker, and other support staff. In the first week of April, I saw him, and he presented us actually quite well. Sometime before the long weekend before Easter, his treating psychiatrist called me to say that he was concerned about this young man who had talked about some suicidal thoughts, and that was news to me. And the psychiatrist was going on leave and wanted me to see him in the interim, and I quite happily agreed to see him on the first day after the long weekend. The psychiatrist was going to see him right up to the end of that week. Over the weekend, this young man jumped from a building and killed himself, and I received a message from the psychiatrist saying that the client had indeed committed suicide. Some of the problems that we had with this client were really a language barrier, problems communicating with his relatives. There was a sense that they were proud of their heritage and did not accept mental illness in one of their members, and to them mental illness was a stigma and a sign of weakness. There were problems in terms of how we connected with the hospital, and there may have been a gap in how serious the problems were, and I guess time will tell. There's probably an inquest into this death. My biggest concern was that were there any communication gaps? Could things be rectified and this unfortunate life not be lost? There are so many other cases that have gone through our clinic, and we can use this as a backdrop to discuss any other issues that come up. Let's process what we understand is a mental illness. To some people, mental illness is a medical concept. To other people, mental disorder can be a legal concept, whereas mental disability could be understood in social rehabilitation terms. Psychiatric disorder becomes part of the domain of psychiatrists, whereas mental health disability may be a view of perceiving disadvantage or loss of ability to be in the workplace and falls in the domain of health and welfare officials, people who grant disability like the ODSP support staff or CPP staff. Another way of looking at it is that the person may be at some psychiatric disadvantage which lies along a spectrum. In the courts, we sometimes hear words like major mental illness bandied about, and major mental illness is a poorly defined concept. How does one equate someone with schizophrenia to somebody who's suffering from a severe anxiety disorder? No doubt, schizophrenia is considered by many people to be a major mental illness, and anxiety disorders not so. However, sometimes individuals with schizophrenia might actually function better than somebody with very severe anxiety. And this arbitrary dichotomy between major mental illness and not so major mental illness blurs boundaries and might confuse who should and should not receive any benefits either from a diversion program in the courts or for disability. The Diagnostic and Statistical Manual, the 5th edition, actually defines what mental illness is and highlights how one approaches the concept of mental illness. They talk about mental illness being determined by the distress that the person might be experiencing or a dysfunction that might exist in the individual. Sometimes the focus might be on discontrol, as in impulse control disorders or obsessive-compulsive disorders. Mental illness as a disadvantage or a disability, or mental illness as an inflexibility or irrationality. Or does the mental illness represent some form of a syndrome or pattern of signs and symptoms? Could mental illness be determined by etiology, as, say, for example, like a substance use disorder? And lastly, is mental disorder defined by a statistical concept and the person being abnormal purely from a statistical point of view? So as one looks at it, one has different views that one can impart or place upon how one sees a person with mental illness. The DSM-5 also looks at mental illness in a complex way as a clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and that is associated with present distress or disability, or with a significantly increased risk of suffering death, pain, disability, or an important loss of freedom. It does make this definition sound a little cumbersome, but it hopefully captures the different aspects that we look at that forms part of mental illness. No doubt, we should not include culturally sanctioned responses to a particular event, for example, bereavement. Whatever causes the current presentation should be a manifestation of an underlying behavioral, psychological, or biological dysfunction in the individual. Deviant behaviors or conflicts that are between the individual and society are not mental disorders unless the deviance or conflict is a symptom or is a dysfunction in the individual as described above. Makes one wonder as to why antisocial personality disorders are considered to be mental disorders other than it comes to the attention of psychiatrists. An examination of most definitions will allow one to see that there could be a physical component in all mental disorders, or most mental disorders, or a mental component in physical disorders. It's a well-known fact that poverty and mental illness have a very close association, and many individuals who have mental disorders gravitate into poverty. Poverty itself breeds mental illness and contributes to considerable distress and suffering. It's also not surprising that many individuals before the courts are from the lower socioeconomic strata of society, and crime and poverty, too, have interesting connections. How then can we contextualize mental illness? I don't have any answers, but I have questions. Questions for the courts, questions for my colleagues, and questions from the audience. What should the courts consider to be a mental illness? To what extent should social problems like homelessness and poverty be considered as contributory factors to crime and mental illness and deserving of intervention? Does an identified individual in trouble with the law require a psychosocial intervention when true biological underpinnings of a mental illness are absent? How does one treat a person who has schizophrenia, presumably secondary to an underlying biochemical or biological disability, as opposed to somebody who's depressed because they have less money and are lacking in housing and are now suffering from depression? How important is it to consider a balanced approach to mental illness, take into consideration medical, psychological, and social factors? Is it time that we look beyond the medical model? I've tried to capture some of the concepts that Dimopoulos has talked about when he compares the medical model with the social model. Medical model here meaning a focus on the impairment and the individual with an emphasis on clinical diagnosis, emphasizing the individual's deficits, and seeing the person as having a problem that needs to be fixed using medical, psychological, or rehabilitation as a form of an intervention. The social model, on the other hand, focuses on the social context and the environment and the individual's relationship with society, seeing social barriers like discrimination, exclusion, prejudices as the problem, and the remedy being the end of discrimination and segregation, and to remove barriers as the solution rather than focus predominantly on the individual. When we deal with our clients in a courtroom, we're often looked at a wide array of disorders, and we can go down a list. Rather than categorize all of them, they can be seen as occurring in several categories like organic mental disorders, brain injuries and epilepsy, psychotic illnesses, which include schizophrenia, other psychotic illnesses, drug-induced psychoses, mood disorders that include bipolar disorders, and major depression. And if you recall, we talked a little bit earlier about the major and minor mental illnesses. These disorders on this slide refer to traditionally as the major mental illnesses. What does one do then with individuals who suffer from intellectual delay, autism spectrum disorders, sometimes also known as autism and as Asperger's syndrome, anxiety disorders and the post-traumatic stress disorders, and other forms of depression and adjustment disorders? What about alcohol and substance use disorders and personality disorders? Can we really compare apples and oranges when we ask what is a major mental illness? One of the most important things, according to Peter Drucker, is the most important thing in communication is hearing what isn't said. And that's quite true about our clients, many of them who may not tell you about their signs and symptoms, but looking beyond their presentation might give you clues as to what they're suffering from. How then does one go through this communicative process? We can look at different ways of how this process might unfold. By communicating with the client, by communicating with the client's representatives, that's the family, the lawyer, therapists, support providers, communicating with the prosecution, who often holds the card as to what might be the likely outcome of a case, communicating with judges who need to know more about the client and who ultimately would decide on a course if this went before the judge, communicating with court staff like bail officers, probation officers, and also police officers in the courts who have apprehended and sometimes helped to regulate the behavior of such clients in the courtroom or in the court corridors. Lastly, should it be our responsibility to be communicating with the government, the municipal, the provincial, and federal government, not only about the plight of our mentally ill clients, but about the poverty and the homelessness that they experience? We know in Toronto the limitations in finding beds quickly for our clients, and how often clients who really need to be in a safe bed are shunted off to a shelter where many of them are afraid and are taken advantage of. In meeting with many of our clients at our clinic, I have distilled some of the basic principles of communicating with a difficult client into 5 major headings: safety, security, privacy, trust, and empathy. most of these terms are self-explanatory, but we can talk about safety. When I talk about safety, one must think about one's own safety. If you don't feel safe, you aren't going to be communicating with your client well. On the other hand, if the client doesn't feel safe, you're not going to get information from the client. If the client doesn't feel that the environment is secure, you are limiting the quality and the quantity of the information that's going to be flowing to and fro. So safety and security of the client are essentially the platforms upon which the communicative process begins. We often find clients in our offices with limited space, people walking in and out of our office, and often clients complain about privacy, while they also include aspects of having security about their conversations. The client does need to feel that this information that they're communicating to us is done in privacy. We have difficulties with that because quite often the very nature of the conversations are to be discussed with the Crown towards a diversion process, and that limits the information that the client might be prepared to share. Often we hear clients say to us that we have been advised not to talk to you by our lawyer, or they would have had some previous negative experiences that prevents them from sharing information. What about trust? How does the person trust the psychiatrist or the mental health professionals when through trust one might find a person is a danger to himself or herself or others, and that trust will be breached by having the person certified to a hospital, many times medicated against their wishes. What about trust as to whether we are working hand in glove with the Crown's office? These things often need to be explained, and the whole process takes time. Lastly, there are issues beyond safety, security, privacy, and trust, and that's about connecting with the client's pain and suffering and explaining or conveying to the client that we may make a difference in the outcome of their case, not only from a legal point of view, but assist the client in obtaining benefits, in relocating, in setting up a social support network. There's no shortcut to empathy in facilitating the communicative process. I've identified some situations where we can identify a specific type of client that might be difficult. An example would be, say, the raging client. Again, the same principles but can be adopted. Your safety first, the client's safety, and give the client time to talk and express him or herself. Have more visits to create familiarity and trust. Sometimes have a colleague sit in. Have the client bring a colleague. Offer food or a beverage sometimes might help to diffuse tension. Talk initially about some of the client's general concerns before one actually gets into the specifics and the nitty-gritty. What about the paranoid or the delusional patient? Work on the assumption that to the client, his or her belief is fact. Delusions cannot be challenged. That's the very basic nature of the definition of a delusion. However, give the person sufficient time and the delusion will become apparent and the issues surrounding the delusion start becoming relevant to the individual, irrespective of how irrational the person might be. This would allow you to understand how the delusion might be instrumental in determining the client's behavior. For example, a paranoid individual might be mistrustful, might express the mistrust through anger and violence. A grandiose individual might present as being rude, condescending, and dismissive. And to understand that these behaviors are driven by grandiose delusions might allow the individual not to react, but to work along with the client, however difficult the client might be. Individuals with nihilistic delusions or delusions where they believe that the end is in sight, that they're going to die, or that it is pointless and fruitless in pursuing anything because everything comes to naught. Such individuals may have an attitude of not caring and have a giving up attitude, and it does require a lot of effort on one's part to try and get them on board and to cooperate with a plan of care. With individuals who have bizarre delusions, they too have non-bizarre thoughts and ideas that one can connect with and allow the interview process to proceed. With the uncommunicative client, you may want to evaluate body language. You might have to depend on collateral information, involve friends, relatives, or workers, set a tone for trust by using simple, straightforward comments, use nonverbal signals to acknowledge leading statements, encourage the client to nod, blink, use a finger to point, write out answers, draw a diagram, or even get an interpreter. With the intellectually challenged client, one might want to focus on developing trust, keeping in mind that it might be useful to talk to the client's guardian or lawyer, because such individuals might be quite willing to trust you and share information that the lawyer might feel might be detrimental to the case. May want to address any fears, create a secure and safe environment for the person to talk to you. Involve relatives, family, friends, workers who have been working with the client. You may want to begin interviewing the client at the client's intellectual level and gradually move up with the level of discussion becoming more complex, evaluating periodically whether the client is on the same page as you. One of the most difficult problems that we have in the courtroom setting and in our mental health offices at the court is dealing with personality disorders and individuals who are malingering. When I talk about malingering, we can talk about individuals who try to fake a mental illness in order to get some advantage, or people who try to deny that they have a mental illness also for some advantage. Within the personality domain, we look for antisocial traits. We also look for other personality disorders, as this helps to understand the context in which a mental disorder can occur. As with all forensic cases, faking ill needs to be considered and has to be kept in mind. The reverse also may be true, and we call that dissimulation, being the denial of an illness or faking well, sometimes out of fear of being stigmatized as having a mental illness, sometimes being sent to a hospital against a person's wishes, or being forced to take medication much against the client's wishes. It is our experience that many clients referred to our Coda office have had traumatic experiences or adverse life events. Many of them have not or never met the criteria for PTSD, that is post-traumatic stress disorders, but compounding their problems are economic hardships and hopelessness and homelessness. Their narrative is highly relevant to understanding and contextualizing the origins of their offending, which will assist the courts and the crowns in coming up with the best possible solution, whether it be diversion or any other alternate forms if a guilty plea is